Okay, thanks for coming. This is our marathon session now. It began with just me, but then I realized that you'll get tired of hearing me talk for 2 hours. So I invited some of my colleagues, Dušan Pavlović from Belgrade, he's an expert in vestibular testing and physiology, neuro-otologist. Mike Puricelli from Kansas City, from the United States, will speak to us about temporal bone anatomy and his very specific way to learn and conceptualize. And then we have Jahnvi Maharaja from Kerala, Kochi in India, will speak to us about anterior skull-base anatomy. And then I will finish up at the end with electrophysiology. Okay, thank you.
All right, thanks. All right. Well, thank you for the introduction. I'm Mike Puricelli. I'm a pediatric otolaryngologist at Children's Mercy in Kansas City. And today I have the opportunity to talk to you all about, like Dr. Fishman said, a different approach to temporal bone anatomy, and specifically looking at measurements to help improve the safety and efficiency. And so we'll talk through some of that. I have nothing to disclose. I'd like to begin with a thank you. I really enjoy the opportunity to come to these meetings, to meet new people, to see new parts of the world, and this is such a great opportunity for me personally and professionally. And so one of the things that I enjoy doing whenever I get to visit other countries and go to these meetings is to learn about the local culture. And I particularly start with the UNESCO World Heritage Sites as I try to decide what would be something interesting to see. So Croatia has 10 World Heritage Sites, and you can see them indicated on the map. We're, of course, in the capital, Zagreb, and as we look at a potential heritage site to visit, there's really several ways that you could get there. The first is you could have a destination in mind, and you can just head in the general direction of that destination with the intention of locating it. Second, you could follow landmarks. That could be streets that you're going on, landmarks that you're passing by, monuments that you see, etc., to help guide you from where you are to where you want to get. The third option is to get directions, and that's really the combination of these landmarks plus the relationship between the landmarks. And then the fourth option is to use navigation, where you have the landmarks, you have the relationship between the landmarks, and you have your progression in real time as you progress between the landmarks. And then finally, you could hire an expert or a guide and have someone else to get you there. And the truth is that this is the same when we think about temporal bone surgery and the same when we think about lateral skull-base surgery. And so the focus of many textbooks is on destinations. I want to get to the round window and insert a cochlear implant electrode, or I want to get to the internal auditory canal and remove a tumor. People talk a little bit about anatomic landmarks in terms of how you get there, and that's an important part of instruction. But really the focus of the talk today is to look at the relationship between these landmarks, and the goal of that is to really help you be more efficient and effective surgeons. Whenever there's a lack of discussion, then you can wind up with problems. You can wind up drilling lateral semicircular canal fistulas, injuring facial nerve, and having other issues as such. So this can be thought of in several ways. The first can be from a transmastoid perspective, and that's where I'm going to spend the majority of time today. It could also be from an endoscopic or transcanal perspective, a retrosigmoid, middle cranial fossa, and so we can look at this, from different perspectives. But the primary focus, again, is to focus on the safety and efficiency for trainees, and so that's where we're going to go to the temporal bone and the mastoid specifically. I think it was interesting at the faculty dinner. We talked a little bit about this concept, and this is what one of the faculty at the meeting talked about, was really the importance of foundational techniques as a stepping stone to be able to do the more advanced procedures and to be able to do lateral skull-base surgery. And then it's represented in some of the skill assessments. Like, for example, there was a great talk about sinus skill development and progression through surgical skills. So the first piece is we need to have safe and sufficient exposure. That includes doing an adequate antrostomy, and then opening the additus and the digastric ridge, and finally identifying the facial nerve. So from an exposure perspective, The middle cranial fossa dural plate averages about 7 millimeters above the spine of Henle, and it averages about 5 millimeters above the linea temporalis. And so as we think about what our soft tissue exposure needs to be superiorly, those are our key landmarks. Inferiorly, we have the stylomastoid foramen, and that averages about 10 millimeters deep to the mastoid tip, which is an important point, for someone who's maybe less experienced. In the adult patient, you can aggressively remove the periosteum down on the mastoid tip without worrying about injuring the facial nerve and get adequate exposure there. It's really important, though, in the young patients, pediatric population, to have caution around the mastoid tip, especially in the patients under 2 years old. You can injure the facial nerve by being too aggressive in that region. This slide demonstrates the growth progression of the mastoid. And as you can see, there's almost a linear growth that occurs up until 6 to 8 years old, and then it really starts to level off. And so, very important point to be aware of. Other things that are important to consider are the texture of the temporal bone is different in younger patients, and so a lot less pressure is required, and there's a lot more bleeding from a marrow perspective in younger patients. As we look at how much superior to inferior distance we need, it averages about 3 to 3.7 centimeters as we're thinking about the incision length for exposure. So in general, the spine of Henle is about 7 millimeters to 8 millimeters to the middle fossa dura. The linea temporalis is about 4 to 5 millimeters below the middle fossa dura. It's about 10 millimeters to the stylomastoid foramen at the mastoid tip. And the tegment of the inferior mastoid tip averages about 30 millimeters. So you'll need a 3 to 4 centimeter incision at minimum to do a mastoidectomy. As we think about the antrostomy, McEwen's triangle is really the core of the starting point to drill. Superiorly, that's the inferior temporal line. Anterior-inferiorly, that's a tangent to the posterior superior ear canal. And then posteriorly, that's a vertical tangent from the posterior aspect of the ear canal. I already mentioned these landmarks. They're equally applicable as you start doing the mastoidectomy to identify the middle fossa and see where the tegment is. It's important to note that the tegment is not straight, and so as you look at from lateral to medial, there's oftentimes a dip in the tegment, and there was a great talk earlier this meeting about CSF leaks and showing a case of injury to the tegment at this site. And so it's just important to be aware of that as you're approaching the antrum from lateral to medial. In terms of the sigmoid sinus, this is probably the most, or at least it's one of the most variable landmarks in terms of its general position. It's about 15 millimeters from the sigmoid sinus to the ear canal. Kerner septum, so this is a consolidation as we move from lateral aspect to more medial aspects of the temporal bone. And this is particularly relevant because it can be complete in some portion of cases. In the literature, it's generally between 6 and 45%, with a much higher rate in patients with chronic otitis media. So these are the general measurements as we look at stepping things from the lateral cortex into the antrum. This is an example of a patient. This is a child who's getting a cochlear implant surgery. As we're looking at defining and drilling in the McEwen's triangle area, starting to open the cortex. This is once we've completed the cortical mastoidectomy, and we can see the antrum with the lateral semicircular canal, which is right there. And so we'll talk about drilling this progression forward to help find the incus and continuing our dissection. So we switched, that was a left bone, this is now a right temporal bone, but showing the same structures as we're progressing through. So there's multiple air cell tracts that are able to be dissected once you open and enter the antrum. So as we look at inferiorly in particular, there's a central mastoid air cell tract, which is all this bone. There's also a number of cell tracts that go up the tegmental tract that goes above the external auditory canal. There's a number of air cell tracts around the sigmoid sinus, and then cells around the facial nerve. So as we look at how much space do you have from the lateral dural plate to the lateral canal, that's variable, but as you're drilling anteriorly from the antrum and approaching the posterior epitympanum, there's generally about 4 millimeters from the lateral canal up to the tegmen. As we look at the sinodural angle of the lateral canal, that's again highly variable, but about 10 millimeters on average. Once you're in the antrum and you're starting to move from posterior to anterior, dissecting up towards the ossicles, there's a structure, the petrosquamous stalactite, which we named after Professor Fishman. And this is a condensation of the Kerner septum up on the superior tegmen, and there's several vessels that run through it, and it's a very useful landmark as you're moving from posterior to anterior, both from a dissection safety perspective, which I'll point out, and also from a pathology clearance perspective. Sometimes cholesteatoma can be hiding up under this structure. So as we remove it, going from posterior to anterior, the average distance from this posterior prominence of the stalactite up to the incus is about 4.5 millimeters. And there's several, here we go. And it has as little as about 1 millimeter distance between the two, so you have to have caution as you're approaching them. The tegmen to the stalactite is about 2 millimeters of vertical distance, and then incus buttress can vary a little bit, but about 4, a little bit more than 4 millimeters. This was recently studied in another project done by some of our colleagues from Poland, and they came to a similar conclusion that this is a reliable and consistent surgical landmark. So as we think about exposing the incus, we'll start with just thinning out this ear canal wall and kind of really trying to there we go. Trying to open the bone up lateral to the incus, so we have a little bit of trough to be able to identify it. We'll look for the incus under the water, which I think we can almost see now. There you can see the incus, and then we'll expose that a little bit better in this case. All right, and there's identification of the incus. Once the incus is identified, the external auditory canal is thinned, and this is generally done, at least in my hands, until there's no air cells left. And that's very important as you think about approaching the facial nerve and identifying that in the vertical segment, so that you don't take an approach that's too posterior and risk injuring surrounding structures. This demonstrates drilling over the digastric muscle. As we can see inferiorly in this bone. I don't oftentimes do that when I'm doing a routine chronic ear surgery. It is a very useful landmark and reliable landmark for the facial nerve. And for example, in the case of absent ossicles or a need to do more extensive air cell dissection, then it's useful to be able to drill those cells and identify that. So the facial nerve, as you can see in this picture, is really the key landmark or the most important structure along with the lateral semicircular canal in doing a cortical mastoidectomy and opening facial recess. So I think of it more of an approach as opposed to a particular path to identifying that structure. If you're too posterior, again, you can risk iatrogenic injury to the semicircular canals. If you're too anterior, you can risk drilling a hole through the external auditory canal. So we need to thin the ear canal, we need to airplane the table, and then it's really important to do monitoring, which is something that will be talked about later in this session. This just demonstrates how a more posterior or a thickened ear canal can direct you more posteriorly than would be ideal. As you think about the descent of the facial nerve, it has a variable course. And so as you look at it from the lateral semicircular canal to the exit of the stylomastoid foramen, about 60% of specimens show a straight vertical descent, and then about 20% bow laterally and about 20% bow medially. And so it's important to be aware that you can have variable position of the nerve. And the mastoid segment fills 25 to 50% of the fallopian canal. I really like this slot position description as we think about identifying the nerve and opening the facial recess well. And that really involves the proper airplaning of the bed and positioning of the patient. So once you've identified the facial nerve or know the approximate position of it, then you'll drill in a more forward direction in the trajectory of this short process of the incus, rather than drilling in a more posterior direction where you're essentially drilling right at the facial nerve. The sentinel air cell is a really useful structure as indicated in this photo, but there's really 7 or 8 landmarks that can be utilized to identify the facial nerve. The most important 3 are the lateral semicircular canal, the short process of the incus, and the posterior ear canal wall. Unfortunately, in some cases of pathology, we just don't have those, or congenital anomalies are not available, and so it's useful to be able to use each of these landmarks to correctly identify the facial nerve. So as I mentioned, the big 3 that really should always be identified when drilling for the facial nerve, and then minor landmarks can be used more selectively. So as we think about what is the approximate trajectory of the facial nerve, it really bisects the lateral semicircular canal as you're moving from superior to inferior in position. The short process of the incus measures about 2 millimeters to the second genu of the facial nerve, and the nerve generally lies inferior to a line that's drawn through the short process of the incus. As you can see where it would be positioned. And so just in the ear canal, so it's no thicker than a few millimeters to be able to do the approach. It's common to get some bleeding as you're drilling in your approach to the facial nerve. The facial nerve has a dual vascular supply. It comes from the stylomastoid and the superficial petrosal artery. And so it's common to see bleeding, right around this area near the anastomosis of the 2 vessels. Chordotympany nerve is a useful landmark. It's one of my preferred landmarks actually as I'm thinning the canal and knowing that I thin the canal adequately to identify it. It exits the mastoid segment of the facial nerve about 5 to 6 millimeters from the stylomastoid foramen, though there is variability in the position of that landmark. And then the digastric ridge, the digastric muscle always lies lateral to the facial nerve, and in general there's about 3 to 4 millimeters distance between the digastric muscle and the facial nerve. Retrofacial air cell tract is indicated on this picture by D is a useful spot as we're looking at a posterior approach to the facial nerve. It's also essential as we're looking at other procedures like subtotal petrosectomy or preparing for labyrinthectomy. Posterior semicircular canal, it varies in position, but generally is about 3 millimeters, 2 to 3 millimeters from the facial nerve. And so as you're doing more advanced or more deeper procedures into the temporal bone, it's really important to not, as you're defining like lateral canal to posterior canal, you'll want to drill in a direction that's away from the facial nerve. You won't want to drill towards it and accidentally backwall the nerve. Jugular bulb varies, but it's about 7 millimeters, the facial nerve is about 7 millimeters lateral to the jugular bulb. So as you follow the sigmoid sinus down and are identifying those retrofacial air cells, you can need to exercise caution as you're doing this inferior part that you don't, again, come under the facial nerve inadvertently. And then it's notable that while the mastoid changes quite significantly by age, the facial recess actually does not. And this is a really nice histologic study that showed that it's actually consistent and constant according to age. So this demonstrates the slot position and then opening of a sentinel air cell. So for me, I won't drill forward until I've already identified the mastoid segment of the facial nerve. And in this case, I think this is a 3 diamond. I'll typically use either a 3 or 4 millimeter diamond burr as I'm doing this dissection. So I think it helps me to have a wide exposure to be able to see things well as I do the approach. This is an example of using the chordotympany nerve as a adjunct. So the nerve is actually right here. Chordotympany is there. And in this case, we did it a little differently because this patient had a previous outside surgery. They took out the ossicles, but hadn't drilled a mastoidectomy yet. And I needed to do a facial recess as part of this management, just stemming the facial nerve there. And then this is an example of seeing kind of, this is a pediatric cochlear implant from beginning to end, and just walks through the general steps of of performing this approach. So we're opening the lateral air cells now, coming down and identifying the dural plate, the tegmen up high, and which is up here, and then this is the sigmoid sinus there. Continue down into the antrum, which is just through these few little spiculated air cells. That's opened into the antrum now. And we'll continue the drilling more anteriorly. And this is where, again, the petrosquamous stalactite can be useful as you're walking that forward from posterior to anterior. We see the lateral semicircular canal, and we also are opening in the direction of the incus. I like to stimulate the tympanic segment of the facial nerve just to ensure that the facial nerve monitoring system is properly functional. I've had one case of pseudocholinesterase deficiency where I thought we were monitoring and later discovered that we weren't. And there's also a risk of injection affecting facial nerve. And so it just gives me an added level of certainty that the monitoring equipment is doing what I think it is. So in this case, we're identifying chorda tympani, which you can just start to see as this pinkish red blush. Drilling a little bit over the stylomastoid artery just to slow down a little bit of bleeding. And then we're continuing to drill down to identify the facial nerve, which we'll stimulate shortly. You can see the track with a bone covering over top of the nerve. And you can also see a little bit of the sentinel air cell. It's opening at this, right there, essentially where we're drilling. And this drilling is really from a posterior to anterior direction, and it's important to turn the drill off. So you complete the move, turn the drill off, and then remove it so you don't accidentally hit the nerve as you're removing your drill. So as we think about deeper anatomy, the semicircular canals form a solid triangle. They're orthogonal in position, and they have a dense bony shell. The tegmen to lateral canal, I already mentioned, varies in position, but somewhere between 4 and 6 millimeters. Inferior to the tegmen to the lateral semicircular canal. The lateral canal, again, lies just over the facial nerve. Posterior canal is just behind the facial nerve at the ampulated portion. There's variable distance between the posterior semicircular canal and the jugular bulb. And then the superior canal is about 2 millimeters anterior to the lateral, it's 2 millimeters medial to the lateral canal here, and it's actually deepest, at the crus communis area. And then Donaldson's line is an important landmark as we're looking for the endolymphatic sac. This is lateral semicircular canal bisection of the posterior semicircular canal, and the endolymphatic sac generally lies just inferior to Donaldson's line. There's a number of air cell tracts that can be opened in approaches to the petrous apex and also in subtotal petrosectomy. And I won't go through the specifics. There was actually an excellent talk about opening and accessing the petrous apex yesterday. The internal auditory canal from a translab approach. So it has about a 1 centimeter horizontal dimension and about 3 to 7 millimeter vertical dimension. There's the falciform crest, which separates the superior and inferior nerves. And then there's Bill's bar, which lies in the vertical plane and separates the anterior and the posterior nerves. So in essence, facial nerve is anterior superior, cochlear nerve is anterior inferior, and then superior and inferior vestibular nerves are superior inferior respectively posteriorly. And then the fundus, or the bottom of the internal auditory canal, is the narrowest zone, getting down to 0.65 millimeters in diameter. As we think about hearing preservation approaches, there's quite a bit of variability from a landmark position perspective. And there's also a significant growth that happens. So for pediatric skull-based procedures, there's a significant difference in approach as opposed to adult approaches. And then there's actually a quite high reported injury of inner ear structures. So this is a multi-institutional study that looked at patients who had either retrosigmoid or middle cranial fossa approaches to the internal auditory canal. and there was a breach of the vestibulocochlear system in 21% of patients. It was identified, and radiographically there was a breach in actually about half of cases. And so significant risk from a surgical perspective, and really important to understand the relationship between these structures. So posterior wall of the tegmen, this is really the relevant anatomy for the retrosigmoid approach. And so this is all petrous bone, and the internal auditory canal lies at the center. And so you can see it here, and that is 32 to 44 millimeters from this posterior wall of the sigmoid sinus. It's about 3 to 8 millimeters deep to the superior part of the temporal bone. It's 4 to 9 millimeters above the jugular bulb, and then it's about 6 to 14 millimeters anterior to the vestibular aqueduct as we're looking at our approach. So generally you can drill about a half a centimeter of bone from the posterior lip of the canal in order to improve your access without injuring an lymphatic sac. As we think about superior approaches, we're thinking about middle cranial fossa, and so the key external landmark is several, but one of them is the external auditory canal. So the petrous temporal bone, it extends from about 16 millimeters anterior to 24 millimeters posterior from the external auditory canal. So we're talking about this dimension. The posterior aspect of the GSPN groove is about 6 millimeters anterior and 25 millimeters medial to the midpoint of the external auditory canal. So those are one of our two key landmarks, is the greater superficial petrosal nerve, and being able to identify that adequately, which is shown over here in this picture. And then the arcuate eminence, or the superior semicircular canal, in the more posterior portion is again indicated here. And so the internal auditory canal is approximated by bisecting the two planes between the between the arcuate eminence and the GSPN. And then it's important to note that the GSPN is dehiscent in 15 to 20% of cases. So if you're doing dural elevation, there's a potential risk to injuring that from an approach perspective. And then as we look at things more deeply, again, the internal auditory canal is at the junction of the angle between the GSPN and the arcuate eminence. And that, again, is about 3 to 8 millimeters inferior to the posterior lip. And then the zygomatic root can additionally be an important landmark as we're looking at the axis of the internal auditory canal, as that will generally project in the direction of the zygomatic root. There's a number of other landmarks that are described and measured for middle cranial fossa approaches. I think that's a little bit beyond the scope of what we're trying to cover for today. The only one that I'll point out is that you have about 1 centimeter or 11 millimeters of distance in the anterior-posterior direction as you're looking at having an anterior-posterior trough around the internal auditory canal from an access perspective. And then I thought this was interesting as people talk about imaging and potential risk mitigation strategies. This group actually is discussed using navigation. And so as we think about that progression from landmark to from destination to landmark to directions to navigation, that's something that's currently being explored. So in summary, we have all of these key measurements from the general approach perspective. And then that's really the foundation in order to be able to do the approaches for lateral skull base procedures. Thank you.
We'll do questions at the end, so I'll leave extra time.
There. Thank you. Could you take a picture if you don't mind? Thank you. Is it okay? Thank you. Okay. Yes. It's okay. This side. Could you put the charger?
So,
Yeah? Okay.
you're full. I think you'll be okay.
Yes. Thank you. Okay, first of all, may I ask, how many postgraduates do we have here? No one? Could you come ahead? You are not going to be penalized for being the only one, don't worry. It's good to have you here. Please. The session is meant for you all, so great. All right. So a very good morning to everyone, and today we're going to learn about practical surgical anatomy. Just an overview about the endoscopic anterior skull base related practical surgical anatomy. As you know, the nose is a powerful sense organ, not only beautifying external appearance, but is extremely important for breathing, olfaction, and now we utilize this natural pathway to get all the way to C2 posteriorly, from anterior to posterior, and laterally into the infratemporal fossa and jugular fossae. With the era of minimally invasive surgery and focus on improving the quality of life, as well as the advent of powerful microdebriders and powered instruments, more and more of minimally invasive surgery is in practice. And meticulous pre-operative planning and preparation of the nose is an absolute essential to be able to practice anterior skull base surgery. The base of which begins with assessing the nose and the endoscopic assessment of the sinuses before planning anything into further skull base surgery. How do we assess the nose? First of all, a preoperative nasal endoscopy with a 0-degree nasal endoscope, a multidimensional CT of the paranasal sinuses to give us a good idea as to the planning, and thus we plan the surgical exposure. Now, the main thing here as an ENT surgeon that we contribute is the planning of the reconstruction of the skull base even prior to the surgery being performed. That is by anticipating the defect, and that is where our role really comes in, and preparing the corridor to the surgery. Coming to the osteology from anterior to posterior, the medial wall consists of the nasal septum, which has 3 parts, the membranous being the anterior, then the cartilaginous, and followed by the bony part. Then the lateral wall, which consists of the inferior, the middle, the superior turbinate, sometimes the supreme turbinate, and the corresponding meatai. We have the arterial supply and the venous supply of the nose, which is extremely important to understand because it is based on this that the workhorse of reconstruction of skull base, that is the nasoseptal flaps and the inferior turbinate flaps, the middle turbinate flaps, any vascularized pedicle flaps are based on this. Coming to the first pass, let's assess the nose based on each pass in endoscopy. The first pass is basically along the floor, running from right the vestibule, along the inferior turbinate, the nasal floor, looking into the inferior meatus, and then the nasopharynx. That is, we're looking at the entire nasopharynx, including the eustachian tube opening. What all are we actually looking at in the first pass? We begin with the internal nasal valve area. Is there any block there? Is the inferior turbinate enlarged? Is the maxillary crest prominent? Is there any bulge in the nasal floor? Is anything really blocking the internal nasal valve? Because if that is blocked, your patient is not going to be able to breathe how much ever space you give him posteriorly. After that, the nasal septum. Is there any anatomical variation in the nasal septum? Is there a gross DNS? Is there a gross deviated nasal septum? Is there a spur? Is there any abnormality in the nasal septum, any swelling in the nasal septum otherwise? Then the inferior turbinate, is it hypertrophied, especially in allergic patients? You have a lot of hypertrophy, and those within deviated nasal septum to the other side naturally have a hypertrophy on the opposite side. That's another point to look at. Then the passage up to the nasopharynx, whether there's any swelling there, any active discharge along the nasal floor indicating sinusitis, and the nasopharynx as such, whether the choana is open, whether the nasopharynx has any swelling, any adenoid enlargement, any other swelling in the nasopharynx from the roof, from the posterior wall, whether the torus is enlarged, whether the eustachian tube is patent, the nasopharyngeal end. So that's the points to look at in the first pass. Coming to the second pass, this is the endoscopic view of the middle meatus. So what are the points we are looking at in the second pass, looking into the middle meatus? That is, we are assessing lateral to the middle turbinate. So we begin with the uncinate process. I'm not able to I'm not able to drag this video further. So what we're first looking at is the agar nasal, the uncinate process. The natural ostium of the maxillary sinus is actually blocked by the uncinate process. So what we see is the accessory maxillary ostia, like we see in this case. Followed by that, the anterior ethmoidal cell, that is the largest one, the bulla ethmoidalis, and then the ground lamella. So these are the main points we are assessing in the second pass, that is the agar, the uncinate process, the ethmoidal bulla, and very rarely you might be able to see the frontal recess with a 0 degree. So the middle turbinate, first of all, whether the middle turbinate, whether it is normal, whether it is a single middle turbinate or a bifid middle turbinate, whether there is any air filled inside it, which is called a concha bullosa, we'll come to that later. Then the uncinate process as such, what is the attachments of the uncinate process. There are many anatomical variants of the superior attachment of the uncinate process, which can be classified as a type 1, which is the insertion of the uncinate process into the lamina papyracea directly. Then there's a type 2, which is the insertion into the skull base, and there's a type 3, which lies freely in the middle meatus. So that is one thing we're assessing. The second being the bulla ethmoidalis, that is the bulla ethmoidalis, depending on the formation or the development of the ethmoturbinals. The bulla ethmoidalis is the most constant and enlarged anterior ethmoid cell, the largest anterior ethmoidal cell that we visualize. And if this is not developed well, a suprabullar and a retrobullar recess is formed, which together is called the lateral sinus of Grinwald. Then there's a type 4 in which there's a type 3 which inserts into the middle turbinate. There's a type 4 uncinate which lies free in the middle meatus. And it is depending on the attachment of the uncinate, the bulla, and the formation of this recess that the frontal recess drainage pathway is further formed. And coming to the ground of the basal lamella, which is the attachment of the middle turbinate to the lamina papyracea. And that is what divides the ethmoidal cavity into the anterior ethmoid and the posterior ethmoid. So we have about 10 to 11 anterior ethmoidal cells and about 6 to 7 posterior ethmoidal cells. Now the point here to remember is the skull base to which these cells go up to is actually sloping downward from anterior to posterior. It's never at the same level. And as the rule goes, the anterior ethmoidal artery, as the rule goes, the anterior ethmoidal artery, if we measure from the anterior lacrimal crest, at about 24 millimeter from the anterior lacrimal crest is the position in skull base of the anterior ethmoidal artery. We'll come to the variations of the same later. Posterior to that, about 12 millimeter lies the posterior ethmoidal artery, and about 6 millimeter posterior to that lies the optic canal. Attachments of the uncinate process, what we spoke about, where the type 1 goes to the lamina, the type 2 goes to skull base, the type 3 goes to the middle turbinate, and the type 4 lies free in the middle meatus. Then coming to the frontal recess and the types of cells. The recent International Frontal Sinus Anatomy classification of the frontal cells is based upon the frontal sinus drainage pathway into an anterior, posterior, and a medial. So it is because, like you see, the angulation of the frontal recess and the frontal beak, the anterior wall curving inward, it is as good as not possible to really assess the frontal recess drainage along with a 0-degree nasal endoscope, which is why the advent of angled scopes has always helped in assessing the frontal recess. So what we like to use usually is a 45-degree, and if that also doesn't give us enough transillumination, then a 70-degree nasal endoscope. And like we spoke about, the cells are divided into anterior, posterior, and medial cells depending upon the frontal recess drainage. Anteriorly, there's the agar nasal, which is the most anterior ethmoidal cell, then the supra-agar cell, which is the anterolateral ethmoid cell, and the supra-agar frontal cell, which extends further into the frontal sinus. The posterior cells are the suprabullar frontal cell above the bulla ethmoidalis extending into the frontal sinus, and then the supraorbital, which lies posterior to the anterior ethmoidal artery. One of the best ways to practically actually trace the anterior ethmoidal artery and avoid injury is to follow the posterior wall of the frontal sinus along the frontal recess and trace skull base. That is exactly where, right behind the frontal recess, posteriorly, as you trace skull base, you will come across the anterior ethmoidal artery. Coming to the third pass. The third pass is medial to the middle turbinate, and what we are assessing here is the sphenoethmoidal recess. So what are we really looking at over here? We're looking at medially the nasal septum. Laterally we have the basal lamella or the attachment of the middle turbinate. Inferiorly we have the superior border of the choana, and from there about 1 to 1.5 centimeter above the superior border of the choana lies the natural sphenoid ostium. That is what we are looking for. That also corresponds to the inferior half of the superior turbinate. So another identification landmark for the sphenoid ostium is the inferior half of the superior turbinate. Why not the superior half of the superior turbinate? Why do we only plan to excise the inferior half of the superior turbinate? Any idea? When we plan skull base surgery and we are approaching the sphenoid and we want to remove the anterior wall, why are we not really excising the superior part of the superior turbinate? What lies there? What important structure is there that will change the quality of life of the patient? The olfactory mucosa. Okay, the olfactory epithelium lies in the superior half. So coming to the third pass. Here we are assessing the sphenoethmoidal recess. And it is actually difficult to do a good third pass in a patient in the OPD setting, because it is actually painful for the patient once you retract the middle turbinate, and that's because the turbinate has nerve endings. So here, as soon as we have lateralized the middle turbinate or the ground lamella, we are looking at the superior turbinate. And then the inferior half of the superior turbinate is excised using a through cut precisely, and then we identify the sphenoid ostium, as you see in this case. That's the sphenoid ostium in view. So the third pass includes the assessment of the medial cribriform, the superior and occasionally the supreme turbinate and the superior meatus, and it is through the superior meatus that the posterior ethmoidal cells also drain into the sphenoethmoidal recess, as well as the sphenoid drains into the sphenoethmoidal recess. So as we spoke earlier, the maxilla, the frontal and the anterior ethmoid drain into the middle meatus, while the posterior ethmoidal cells and the sphenoid drain into the sphenoethmoidal recess, medial to the middle turbinate. Then coming to the Quiros classification, which gives us the depth of skull base, the depth of the olfactory fossa, which is 1 to 3 millimeter in type 1, 4 to 7 millimeter in type 2, and 8 to 16 millimeter in type 3. This is another point to assess in third pass, as well as on the scan, of course. Then the sphenoid ostium, further speaking about it, there are three approaches to the sphenoid. One is the medial, which we just spoke about, that is lateralizing the middle turbinate going through the sphenoethmoidal recess. Then is the intermediate approach, where the basal lamella is excised in order to, not excised, but is punctured in order to look at the superior turbinate through the basal lamella. And looking at that, the superior turbinate inferior half is cut and we look at the sphenoid ostium, identify the sphenoid ostium. That's the intermediate approach. And there's a lateral approach where we have dissected, done an anterior ethmoidectomy, gone through the ground lamella, gone to the posterior ethmoids, got to the last cell of the posterior ethmoid and punctured inferomedially. So the posterior ethmoidal cell is always at a higher level and the sphenoid is usually inferomedial from the last cell of the posterior ethmoid. And the last cell of the posterior ethmoid, when we keep a suction there and measure up to the nostril, is a 7 centimeter measurement. That was taught to me by Dr. Fishman, always demonstrated practically. All right, so the point here to note is that sphenoid sinus pneumatization is different from a pediatric age to adult age. So at birth, it's only an erythropoietic marrow. By 7 years, it reaches the sella, and by 14 years, adult size. There are different types of pneumatization, which is the conchal type, the pre-sellar type, incomplete, and the complete sellar type. Now, this is extremely important to assess in the sagittal view in the CT scan pre-operatively. If you have a patient with a conchal or a pre-sellar pneumatization, beware. Doing a pituitary lesion in this kind of a patient is almost a contraindication in a conchal type. In a pre-sellar type, you're going to have to do a lot of drilling of cancellous bone. Now, this is specially for you. Look at the sella like a clock. Okay, the sella being the center of the clock. At 1 o'clock is the lateral OCR on the left. The 2, 3, 4 is the cavernous ICA on the left. The 5 being the paraclival ICA. The 6 being the clivus. The 7, 8, 9 being the right cavernous. The 7 being the paraclival IC on the right side, the 8, 9, 10 being the cavernous IC on the right side, and the 11 being the lateral OCR on the right side, and the 12 being the planum and the tuberculum. So look at the sella once you open the sphenoid and have a wide picture once the intersphenoid septum is taken out and you have exposed lateral to the lateral opticocarotid recess. This is the view you expect, and this is where you should expect all the vital structures, that is the optic nerves and the carotid running beside the sella. One important point to take care of here, like we just spoke about earlier, is about how to preserve olfaction, because in this era, patients are more and more aware, and we also must be aware about preserving as much normal mucosa as possible and also the olfactory epithelium, because that really significantly affects the quality of life of the patient. And olfaction should never be considered an undervalued sense. These tips and tricks to actually save the olfaction we will come to when we are talking about the nasoseptal flap. Once again, so coming to the anatomy and the surgical technique of the nasoseptal flap, we are speaking about this because it is based on the arterial supply of the nose, and we have to do this planning as soon as we begin at the beginning of our surgery itself when we are looking to do an anterior skull base surgery. The sphenopalatine artery is actually the pedicle on which our flap is based in a nasoseptal flap. So the SPA is the terminal branch of the internal maxillary, which enters the nose through the sphenopalatine foramen, traversing the pterygopalatine fossa. That is, it is the continuation or the terminal branch of the internal maxillary artery. The internal maxillary is lying within the infratemporal fossa, behind the posterior wall of the maxilla. As you trace your middle meatal antrostomy and go posteriorly, what you will find is the crista ethmoidalis, and that is the crucial landmark which tells you that posterior to that lies the sphenopalatine foramen. This lies in the perpendicular plate of ethmoid. At the foramen, it is supposed to divide into two branches, but sometimes it branches out even before coming out through the foramen. And it is said, according to literature, that there can be about 7 branches of the sphenopalatine artery. The anterior branch runs along the inferior turbinate and the lateral nasal wall, while the posterior branch goes as a septal branch and runs in the submucosal plane. And this running in the submucosal plane above the perichondrium and periosteum is what gives us a very good nasoseptal flap. So when we do a nasoseptal flap elevation, our dissection is in the submucosal plane. And if that is maintained, we can use this flap even in revision cases. So the nasoseptal flap is created at the beginning of surgery, which again highlights the importance of preoperative planning. What we do is a topical vasoconstriction followed by an inferior horizontal incision, which is 0.5 centimeter above the nasal floor, the anterior limit being the mucocutaneous junction. Let me take you directly to the video actually. So we begin with topical vasoconstriction and identifying the sphenoid ostium, the level of the sphenoid ostium and the superior border of the choana. No. Can I forward this video? Is it possible? No. Sorry. So we're now actually just going to place a topical vasoconstriction using adrenaline, dilute adrenaline. And once the sphenoid ostium is identified, we decide the level of the incision for the nasoseptal flap. Now the nasoseptal flap has multiple modifications now, depending on the expected size of the defect. A mini nasoseptal flap can be taken and the mucosa can just be pushed down. Those are called rescue flaps to get enough of an exposure of the anterior wall of sphenoid and complete surgery. Or if it's a large expected defect, especially with suprasellar extension and you expect CSF leak, you could plan a large Haddad flap or a large nasoseptal flap right in the beginning all the way up to the mucocutaneous junction. And if there is significant lateral defect expected, we can even involve the nasal floor mucosa. So here, as we have lateralized the ground lamella, we are visualizing the superior turbinate. Followed by topical vasoconstriction medial to the superior turbinate. Which gives us a view of the sphenoid ostium. I'm sorry, I'm not able to forward the video quickly. This is... And like we spoke before, in order to preserve olfaction, the superior incision, that is the superior horizontal incision, is given at the level of the sphenoid ostium, maintaining that level up to the anterior end of the middle turbinate. So the axilla acts as a crucial landmark in order to preserve olfaction. And this incision can be brought all the way anteriorly up to the mucocutaneous junction to get a large nasoseptal flap. And what I'm showing here is the 3-point landmark, which actually can help us also identify the sphenoid ostium, that is above the superior border of the choana. If we take a number 2 suction catheter, 3 points above the superior border of the choana is the expected sphenoid ostium. Now, the inferior incision is taken along the superior border of the choana, and if we are expecting a large lateral defect, we can include the nasal floor mucosa as well, as I have done in this case. One of the tips in avoiding a tear while elevation of the flap is to start doing your elevation inferiorly once the incision has been placed, especially because at the area of the maxillary crest, there are crisscross fibers that go into the bone, which will actually end up in getting torn if we don't elevate initially there. And that's the superior incision, which can actually go higher after we have crossed the axilla as we come anteriorly. And then a vertical incision connecting both at the mucocutaneous junction. A vertical incision communicating with both, and here it is extremely important to remember not to perforate the cartilage and go to the other side. So you don't have the cartilaginous septum hanging loose. Yes, and like we spoke about, always inferior elevation is to be encouraged first. I have shown this especially because you need to realize that it is difficult to dissect there, and to avoid tearing, it is always important to do a sharp dissection sometimes at that point. And here we are dissecting in the submucosal plane. At the same time, if you have a patient with a gross DNS on one side and your only option is to take a flap on that side because there's significant lateral extension on the other side, just go ahead like a septoplasty. That would also be a good way to elevate the flap. And the lateral extent of the flap is up to the palatovaginal canal. All right. Other vascularized flaps is the rescue flap, which we just spoke about, which is a mini nasoseptal flap, and the other flap which we do, which is a reverse flap. That is, instead of wasting the mucosa of the other side and just excising and letting it go or become a free mucosal flap, the mucoperichondrial and the mucoperiosteal flap on the opposite side after the posterior septectomy is done is reversed and placed in front to cover the cartilage. So this is actually a mini nasoseptal flap, which can later be extended into an entire nasoseptal flap if required at that time and if there is CSF leak. So just like the nasoseptal flap is a posterior pedicle flap, posterior base pedicle flap, a reverse flap is an anterior base pedicle flap. That is a rescue flap, which is only going to be pushed down on both sides in order to get exposure of the keel, the posterior part of the septum, and the anterior villus sphenoid on both sides. While what I am demonstrating now is the mucoperichondrial and the mucoperiosteal flap on the opposite side is brought to the side where the flap has been taken from, that is on the bare cartilage, after the posterior septectomy is done. After the posterior septectomy is completed, a posterior incision vertically is placed between the superior and inferior incision on the other side, and this flap is rotated and brought to cover the cartilage which is exposed. You will see that now. Yeah. And this is then sutured with quilting sutures. This is just to show the postgraduates about navigation guided surgery or image guided surgery. What we are doing, unfortunately, the audio which is incorporated is not playing. So, navigation guidance, otherwise called image guided surgery. Can you hear that? After a patient is positioned and draped, registration process is done using the navigation probe, placing the probe externally at fixed anatomical bony landmarks, allowing a correction of about 2 millimeters. In anterior skull base surgery, the probe is placed at the lateral canthi, the root of the nose or the nasion as the fixed bony landmarks. Once the accuracy is cross-checked, soft touch all over the forehead is achieved along the eyebrow, and depending on the tumor, the remaining landmarks are selected for soft touch. The ICA has been marked on both sides and the tumor is blue in the center. The probe is now pointing onto the left inferior turbinate. This is a small demo of the image guidance. The navigation screen is simultaneously displayed. Next, we point onto the left middle turbinate, followed by the remnant superior turbinate in this case. This was a revision case, and we are pointing onto the remnant superior turbinate. The anterior wall of the left sphenoid. There's a slight delay in the matching in both videos right now. Next, we move on to endoscopic anatomy. So, once we come to the anatomy, one of the most important things to remember is also the anatomical variations that we should be looking for, which starts with as simple as a nasal septal deviation, which could actually be troublesome while the elevation of the flap. The concha bullosa, coming to each one of them. The concha bullosa, which is an air-filled middle turbinate. So here we are looking at the different types of deviation, which could be an anterior dislocation, a C-shaped dislocation, an S-shaped dislocation, or a sharp spur impinging laterally on the turbinate, or even a septal tubercle, which is the thickening of the nasal septum. Here we have a gross deviated septum to the right. So if we have a flap to be elevated on this side, it would be ideal to start as a septoplasty, rather than starting as I demonstrated the nasoseptal flap before. Then we have a sharp spur, where again during elevation it is important because the mucosa is usually stretched and thinned out there. It's important to do a sharp dissection so that we don't get a tear in the flap. Then a prominent maxillary crest or a prominent palatine crest can come in the way and also block the internal nasal valve area. Then a concha bullosa, which is an air-filled middle turbinate, and that's how it looks on the CT scan, can also be troublesome during dissection and needs to be significantly lateralized or the middle turbinate excised. And then a bifid middle turbinate. Then coming to other abnormalities like an Onodi cell. Now, what is Onodi cell and why is it so important? It's basically the last posterior ethmoidal cell which pneumatizes and enters the sphenoid, and the importance is usually a dehiscent optic nerve which you might find inside it. According to scans, there have been about 49.5% of Onodi cell prevalence, and the most common pattern is the combined type, that is the lateral and superior to the sphenoid. The other two being only lateral or only superior to the sphenoid. So look out for the Onodi cell, look out for a dehiscent optic nerve, which in males it is found to be 11.3% and in females about 9.9%, and a dehiscent carotid canal, which could be about 34 and 22% correspondingly in females and males. The whole point here being that assess your scans well yourself, because getting to the sphenoid ostium, feeling happy that we found it and just going through with a suction to enlarge the ostium would not be right, especially in these kind of cases. You could go hit straight away the dehiscent carotid. Then coming to the pneumatized, the various patterns of pneumatization of the sphenoid, where you could find a pneumatized anterior clinoid process, a pneumatized pterygopalatine fossa, which could be a large lateral recess of sphenoid, and if you could tell me what we're looking at now. I'm moving away from here. What are we looking at here? A pathology in the left sphenoid. Yeah, Yeah, so this is a CT scan coronal which is showing a pathology in the left sphenoid. This was a 60-year-old lady that just came to me 2 weeks back, pouring CSF through the left nostril. And this was actually a very, very small defect in the bone here, but a large encephalocele, and she's pouring CSF. We're going to repair her next week. So the thing is, if there is significant pneumatization of the lateral recess or the pterygopalatine fossa, look out for such abnormalities. Here, you can also clearly see the foramen rotundum, and you're looking at the median here, and the foramen rotundum here, the median is not seen well here, but in between both, when there is a defect, it's also called a Sternberg's canal, a lateral recessus sphenoid defect. Then coming to a dehiscent anterior ethmoidal artery, we spoke about how it can be identified based on measurements from the anterior lacrimal crest, and another practical way of identifying the anterior ethmoidal artery is following the posterior frontal table or the frontal recess. But it could be that the anterior ethmoidal artery is lying in mesentery. It runs about 45 degree in angulation from the lateral to the medial wall, that is from the middle turbinate to the lamina. But sometimes it could be running only within mesentery and the optic canal could be dehiscent, and at that point it could be prone to injury. Correspondingly, I'm showing you the CT pictures of the same, where a normal anterior ethmoidal artery completely lying within the canal is shown as a nipple sign, while that lying in the mesentery is shown quite below skull base on the left side. Next, coming to different pathologies in the nose that you should also rule out during a preoperative planning, which would be an active fungal debris which could be seen in the middle meatus, or an active infection seen in the middle meatus, active sinusitis which could be seen. All of these have to be treated before we take a patient for any planned dural opening, any planned skull base procedure. And the other points again to look at is polyposis. And then there are the rare ones, so I'm finishing now, where the nasal endoscopy can sometimes reveal a mass in the nose, but every mass is not something that's coming from the sphenoid or maybe something that's coming from the sinuses. And this was actually an intracranial pathology. It was a prolactinoma which had gone through the inferior infracellular and into the sphenoid and into the nose. And this patient, after 3 months of cabergoline therapy, had significant reduction in the size of the tumor and now is leaking CSF, and now we're going to repair him for the CSF leak. So once again, know your anatomy, and if you know your anatomy well, nothing can stop you from extensive dissection. This is where I work, and thank you very much for the opportunity. Thank you, sir. And I would like to invite all of you to a cadaver dissection course which we are conducting in April in Hyderabad. Yes. I hope you got some benefit out of this. Thank you. So do you need this? Do you need this connector? Yes. Sorry, it was... The videos were a bit slow, sorry.
Okay. You're up.
Thank you.
Good.
Hey, hello. Thank you, Dr. Fishman, for inviting me for this prestige congress of skull-based surgeon. I'm not a surgeon, and I'm invited to present how you will find a patient with vestibular schwannoma, which eventually Dr. Fishman is going to operate. Okay. Is this for a...
Yeah.
Forward, and this is a pointer, but it doesn't.
Okay. Okay. So, this is a friend of mine, 53 years old, with ringing in the ear. Very frequent symptom, and he asked me, oh, when can I come to your office to see me, and so on. So next week, and after a couple of months, he writes for audiological assessment. And you see his hearing. For 43-year-old male, it's, let's say, considering age group almost normal, very slight asymmetry, and regarding his symptoms, that's ringing in both ears, it's not something we should suspect. But what's the reason? How can we make a diagnosis of vestibular schwannoma even in these patients? He declined any vestibular symptoms. Well, actually, check for his balance. Well, usually, if you see a patient at your office coming with a balance problem, you always do hearing testing. Why not? It's in opposite direction. If the patient comes for some hearing problems, we know that inner ear is the organ with the two senses all together, and so it would be a good idea to check at least balance in those patients. So we have a very good signs of affection of vestibular sense. On the left side, head impulse test is positive, and compass walk, he drifts to the side, and he is not even, he can't complete the test, he is falling. And ABR, also helpful, and in this case it showed prolonged latency on the left side, and that's the reason how we make a diagnosis of vestibular schwannoma in that patient. This is next patient. Also a lady with relatively young, 43-year-old, and when she took headphones from her kids, she realized that the left headphone doesn't work. Then she swapped and, oh, it's not the headphone, it's something with hearing, and she come for hearing testing. Very sharp decline of hearing, sorry, in high frequency, sorry, can I return? No.
Yes, yes, this goes back.
Sorry. And, well, but her family history is positive for a hearing loss. Father, uncle, all of us have some hearing problems, and we don't see much of asymmetry in her hearing loss. So what should we do in this patient? How can we make a diagnosis? Of course, just to mention, no vestibular symptoms. Please, can you play a video, please? Oh, the idea is to look for a patient's eyes, and you see very strong gaze-evoked nystagmus. Well, here is, let's say, large amplitude, low frequency, but and when she looked to the other side, also gaze-evoked nystagmus. This is a little bit more high frequency. This is what we call Brunn's nystagmus. Thank you. And actually, this was indication for MRI and discovering a vestibular schwannoma in this case. So at least a minimal of vestibular assessment is needed. At least to see if there is nystagmus, head impulse test, and compass walk is something which I frequently perform in patients with asymmetrical hearing loss. And here is an example of a patient, just 2 episodes of strong but short vertigo spell. For 10 seconds, he felt a vertigo spell at 2 occasions. That was the reason of a visit. Oh, he knows that he doesn't hear on the left ear for 13 years. It was some concert in Kotor. After that, doctors tried with hyperbaric chamber. It didn't help a lot, and he used that he don't have a hearing on the left side. But you see how big vestibular schwannoma he has in left cerebellopontine angle. And this is the test. Well, in this case, head impulse test didn't help a lot. It was negative. But video head impulse test shows slight symmetrical reduction. And what we see here, very strong vibration-induced nystagmus telling us that something's wrong with the left vestibular sense. Even CVAMP was normal. And here is a small study at our office of 33 patients with vestibular schwannoma. You see, in half of the cases after assessment, we knew the diagnosis. MRI was just to confirm it. But in other half of the patients, 32% of patients was suspected to have something else. Most of them because showed central vestibular signs, and two patients was with ear disease, one veneer, other was other otologic disorders which can explain hearing loss. And just in 14% of patients, it was just indication to check for MRI, and then it revealed schwannoma. So now we want to see what was the result of the testing in order that we can make better statistic, that means to recognize vestibular schwannoma in more cases. The age group, 30 to 93-year-old, male woman was pretty much the same, and average age was 58 years. The reason for coming and visiting doctor was pretty much the same, 37% because of vertigo problems and 37% because of audiological symptoms, and almost third with both symptoms. Well, actually, that doesn't mean that vertigo patient didn't have audiological symptoms. We'll see that. But you know, when a patient feels dizziness or a vertigo, he usually, almost in 100% of cases, visit doctor because he is afraid. But when you have some kind of a hearing loss, oh, I'll go to doctor later, and so on, so on. For example, these are 3 patients with vestibular symptoms. We also mentioned the first one with 2 short vertigo spells and hearing problems from 13 years ago. Other old patient, 19 years, he was unsteady, and he had some acoustic trauma 30 years ago that explained his hearing loss on the left side. Also, middle-aged person, 54 years old, with vertigo and hearing loss after ear infection 15 years ago. So, you see, vestibular symptoms were present like unsteadiness, vertigo, or in some cases with acute vestibular syndrome. There were 3 patients with BPPV. Auditory symptoms were hearing loss and in some cases hearing loss accompanied with tinnitus, or in some cases it was sudden sensory neural hearing loss. Some showed fluctuations, but eventually it was not classical fluctuation, but was sudden sensory hearing loss for a second time. And neurological symptoms in just one case. And here are symptoms all together, let's say combination. Patients had just vestibular or just auditory symptoms in 47% of the cases, but usually in most of the cases they showed some kind of a combination of vestibular and auditory symptoms, like in these groups. For example, the unsteadiness and hearing loss and tinnitus, vertigo and hearing loss. And we have a couple of cases with acute vestibular syndrome and sudden sensory neural hearing loss. Probably it was infarct of the inner ear, because vestibular schwannoma pressed labyrinthine artery. That could explain that clinical presentation. We have 3 cases of patients with BPPV. So is BPPV maybe some kind of a manifestation, or can be a vestibular schwannoma? Well, no. 2 cases were BPPV on a contralateral ear. And that means actually that BPPV is very frequent diagnosis. That means symptoms of a positional vertigo brought patients to a doctor, and then eventually, after examining and seeing asymmetrical hearing loss or some other vestibulopathy, it was indication for MRI. That means they didn't have symptoms. They come for one thing, and then eventually we recognize they suffer something else also. Description of unsteadiness. Well, most of these patients felt worse in a dark and on uneven ground, and some have difficulties to hold stride in a stride direction, or have to cope with this. And eventually, vertigo description for our dealing with vertigo patients is very important because of how patients describe their vertigo attack. We can assume which diagnosis is it. But in this group of a patient, we see very diverse vestibular. It can be very short spell of a vertigo, or it can last for minutes, hours, days. And the description of a vertigo attack can range from slight dizziness to very strong vertigo. So no, let's say, some kind of a pattern. Also with the hearing loss, most of them have unilateral, that means asymmetrical hearing loss. We mentioned and showed some patients with a sudden sensory neural hearing loss, and also in a couple of patients there were fluctuation of hearing. That means they presented with a sudden sensory neural hearing loss, which later on improved, and then later they developed sudden sensory neural hearing loss again. And here are results of audiovestibular testing. Well, still, hearing asymmetry is something which is mostly present in those patients. We have a few of them with slight asymmetry, but 82% with obvious asymmetry of a hearing loss. Look how it looks like. We counted how big asymmetry it is. For example, asymmetry of 40 to 60% between ears was present in almost 40% of patients. The bigger or less degree of asymmetry was less present in a less number of patients, as shown on this graph. Head impulse test was 50-50, but video head impulse test recognized cases also which couldn't be seen positive on the bedside head impulse test examination. And here is vibration-induced nystagmus, which was positive in 82% of the cases. But when the test was performed with video nystagmography, that means good suppression, without fixation, with the Frenzel goggles, which also are helpful in not to suppress fixation. They are not so good as the video goggles. You see much less positive results. So I would suggest you to use video nystagmography. And head shaking nystagmus was also present positive in half of the patients. And in some of them, it shows this central vestibular sign like downbeat or biphasic nystagmus. Hyperventilation test was positive in 3 of 5 patients. We didn't do that test in most of the cases because that test was not so popular during COVID period. And but compass walk test, which is really simple. Patient close eyes and walk 1 step forward, 1 backward for 10 times. It's not difficult to perform it, and it was frequently positive. Of course, usually it's ipsilesional, but sometimes contralesional. Bucket test showed positive results also in half of the cases. Bithermal caloric test showed in almost 80% of patients to be reduced on the affected site. Also, ABR test showed similar results, prolonged latency, absent waves, and also almost 80% of patients. VAMPs can be helpful. No response or prolonged latency in 60% of patients. Very good sign of affecting the inferior vestibular branch, which can be helpful for a surgeon to know in planning surgery. And you see central vestibular signs were present in almost quarter of the patients. What were central vestibular signs? Well, most of them had gazy walk, Bruns nystagmus, very characteristic for vestibular schwannoma. We saw a video of a patient with typical Bruns nystagmus, and it's not something which is difficult to examine. And don't take much of your time to see if there is gaze evoked nystagmus. Of course, some patients have a combination of some central nystagmuses, like rebound, upbeat nystagmus, biphasic gaze holding nystagmus, and some problems with saccade or saccadic pursuit, the positive Romberg and positive cerebellar signs or trigeminal asymmetry was also something we found in this patient group. This is an example of schwannoma which can be present intracochlearly, and this was discovered in very late course of a disease. And these are examples of patients with asymmetrical hearing loss. Some of them suffered vertigo or unsteadiness, and this is how audiograms looks. The answer to this question is yes. We should evaluate any hearing asymmetry. And I'll show a few, just if we have time, we'll show just few cases which are not included in this study. This is a very young patient coming back from excursion in a school, and she noticed some poor hearing on the left side. Some poor hearing means that left ear was unfortunately deaf, but right ear also was with significant hearing loss. She didn't have some vestibular problems. And unfortunately, this was indication to do MRI, which showed neurofibromatosis type 2. This is a case which illustrates a patient with a couple of diseases. That means if we have one disease like multiple sclerosis, that doesn't mean that all of the patient's problems come from that. She came to visit me because of a BPPV, and but she also have MS, and also because of MS, frequent MRIs revealed vestibular schwannoma at the left side. And this is an example of a very small vestibular schwannoma without any symptoms and, of course, without visiting to the doctor. But eventually, this was also accidentally found because patient lost consciousness, and that was indication for MRI and very small vestibular schwannoma with still good hearing, 10 decibels. And the conclusion is, and what I would suggest you, that in patients which you evaluate for a hearing, especially if you find some hearing asymmetry, you should perform at least a minor vestibular examination just to see if there is nystagmus, what's head impulse test, if you have possibility to do vibration and head shaking, and of course compass walk. You don't need any special equipment for these tests, and it can be very informative of if there is also vestibular asymmetry, which will of course lead to diagnosing a patient with vestibular schwannoma. Thank you very much.
Okay, so thank you all of our presenters. Now I will cut mine to the minimum so we have a little bit of time for questions for everyone. But I'm going to speak about electrophysiology. So we've gotten anatomy, we've gotten vestibular physiology, and I'm going to speak a little bit about electrophysiology. Okay, good. So, let me see, and first, please just take a picture, so you have this information available for you, because, let me see here, what happened? Okay, does it come back to the, no, I guess not. I went to slideshow, sorry. Okay, we'll go like this then. Okay, good. So take a photo, take the context, because on my YouTube channel, there is videos of many of the videos that I'm going to show you, and we will also post this video that we're taking now, so you don't have to run around looking for it. So, and also, you can take a picture of this. This is the QR codes for my 2 websites. The first one on the left has links to the other websites as well as the YouTube channel, contact information, and the other one is being updated right now on the one on the right, which has also many videos and many informational materials. So, okay. So the first thing I want to talk about, a little bit about the surgical anatomy of the facial nerve with regards to the electrophysiology. And the facial nerve is the main nerve that we're monitoring during skull-based surgery, especially lateral skull-based surgery. And there are different thresholds for stimulation using our facial nerve monitoring depending upon the different locations of the facial nerve. And it's fairly consistent. So we just, in order to move things along a little bit, one thing that we have to take strongly into consideration is that, here it is, good. So the thickness of the epineural sheath in the intratemporal facial nerve is getting thicker as we expand, as we progress from the more proximal to the more distal. So there's a significant increase in the thickness as we get to the vertical segment.
And that impacts the amount of current that's required to get a stimulation, because we have to drive the current through additional materials. So we will expect to have lower current requirements in the more proximal segment and higher current requirements and the highest level of current requirements in the stylomastoid foramen. In the stylomastoid foramen, and you should do this if you have an opportunity in the temporal bone lab, if you dissect open carefully under high magnification in the stylomastoid foramen, you will find that the actual nerve fibers are on the medial aspect of the stylomastoid foramen and the anterior. So it's anteromedial because it's progressing down and then going up as it goes out into the extratemporal facial nerve. So there's a fair amount of thick fibrous tissue that's protecting your facial nerve. That's why when I find the facial nerve, I almost always go first to the digastric ridge and take that down and establish that as the primary landmark because it's very safe there. You have a cushion of protection. And then I go up towards the incus and the lateral canal and connect the two. Because in this area below, you have this thick fibrous protector. In the parotid gland, we have the branches, and at this point, you have only an epineurium, and you don't have any more of the bone. So the requirements for stimulation drop. Okay, so we've lost the extra, so the highest amount of current is required at the stylomastoid foramen. So in the brainstem, at the root entry zone, and this portion here, there is no epineurium. So this is completely raw nerve. It doesn't obtain its covering until it goes into the labyrinthine segment. So in this area, the intracranial segment, and at the brainstem, you can expect to use a current of 0.05 milliamps. This is typically the low end, below which you will not get a stimulation. But it's variable. In some situations, you may get it at 0.03. But I use typically with acoustic neuroma surgery or posterior fossa surgery, I use 0.07 just to make sure I get a depolarization. So I just go a little bit above what is the minimum expected threshold to not have a false negative process. So for me, 0.07 is important. And this is why it's important to have a neural monitoring system that has this fine control at the lower ends. Some of the systems, they have a choice of 0.1 and then 0. So you really need to have a system. There was the Medtronic laptop system only had this breakdown. It didn't have the fine control. So you want to have this sub 0.0 control when you're working at the brainstem. Now, in the internal auditory canal, now we're going to consider that when we're first approaching the facial nerve in the internal auditory canal, we are usually approaching it from the dura side. So we've drilled the bone off, and now it has a dura on it. So the requirements are to go through the dura and then to the raw nerve, because it still doesn't have an epineurium, but now it has dura and it has tumor. So if you're drilling the internal auditory canal and you want to verify the integrity or estimate the position of the facial nerve, you need to go through also the dura. So you need to use about 0.15 to 0.3 milliamps to go through the dura and stimulate the nerve. Okay, so this is the range. I will always use a slightly higher level and then dial it down. Okay, and by dialing it down, you are narrowing down your zone of stimulation. You're getting a higher level of precise localization. And something that Jason, my colleague, mentioned yesterday in his lecture is that we use monopolar for this localization. So if you have a bipolar stimulator, you're not going to get a spread of field. So when we're localizing, we want to use monopolar because the monopolar is going to give a spread of the electrical current, and you're going to get stimulation at these higher levels because you're able to spread this higher amount of current. And then you're going to dial down the level of stimulation in the monopolar setting to be able to more exact pinpoint your anatomical relationships. Now, when we get to the labyrinthine segment, it is just beginning to get this epineural part. Okay? It's entering into here and it's getting this little fiber. But at the labyrinthine segment, it's very thin. So if you stimulate, if you remove the bone off of the labyrinthine facial nerve completely, it's clear, you can get it as low as 0.05, which is exactly the same as the intracranial. Okay? Because, and another reason for this is this, all the nerve fibers are all very, very compressed and in a very small area, so you're able to recruit a lot and get a stimulation. So even though it has an additional fibrous coat, it's a very compressed setting, so you can get it at very low stimulation. But if there's a little bit of bone or a little bit of fibrous tissue or the sheath still on it, you can get it at around 0.1. So I begin at these higher levels. I say, okay, here's the labyrinthine segment. I start at 0.1 and dial it down a little bit. When you get into the geniculate, you know, the geniculate is variably covered. So in sometimes, even if it's in the bone and there's a bony cover, you have a lot of vascular channels. And Mike, I think you mentioned about the blood supply to the facial nerve. So these vascular channels act as like wires going directly to the ganglion. So you can stimulate the area of the geniculate ganglion at relatively low levels, okay? 0.5 is usually my starting point, but you can get it even lower because of these vascular channels, okay? So you have to be aware of that. You even though you're getting it very low level, you still sometimes have some bone to remove because it's going right through the blood vessel and right into the nerve. Now, as we move forward, inside the temporal bone, the horizontal portion, proximal to the oval window, is covered by the thinnest amount of perineurium. So we tend to see levels of 0.5, sometimes 1, but 0.5, usually on the lower end. And in some systems, depending on another factor, which I'll get into next, is your width of your stimulus. So in many of our systems, like the Medtronic NIM system, which is probably the most commonly used in Europe, it's a fixed stimulus width. So, but in some systems, you can actually reduce the stimulus width or widen the stimulus width. So depending on the width of your stimulus impulse, you get some variation. Okay, so you have to play with your system and learn it like an instrument and recognize. So if you widen the pulse width, you're going to be able to get activation at a lower milliamplitude, okay? Because you're essentially giving more energy in there. But this is the point where you'll expect it to be at about 0.5. And over the oval window, it's the thinnest bone, and we know that a considerable number of patients have a natural dehiscence. So you can get stimulation even lower, even through bone, because it'll just kind of arc in and get to some exposed fibers. So you can expect to get stimulation at 0.3. But if you're just doing a confirmatory stim, I usually set it at 0.5. You know, you don't want a false negative. So I use 0.5 to 0.3 right over. And what's important about this is, you know, you don't want to overstimulate. If you have a long, complex case, especially with CP angle surgery, you don't want to give electrically induced neuropraxia. So if you're working, for example, a cholesteatoma over the oval window, and you also want to be able to localize, right? So if you use too high a current, you're also not going to get precise localization. You're going to get stimulation even though you're kind of far away if you have too high a current. So when I'm working over the oval window area and using the probe, I will use around a 0.3, and I maybe even go down to a 0.15, so long as I'm still getting stimulation. You can even, as I mentioned just before, you can lower your pulse width to get even more precise stimulation because you're using this now as an identification and dissection tool. When you get to the second genu, and this is the area over our posterior tympanotomy, right, that Mike showed earlier, you're verifying, he's reaching up over the top in the middle ear to get a confirmatory stim integrity, which also points out a very important, if you're concerned about a certain area, you want to verify integrity by going proximal to that area. You know, in some patients, there's a lot of vascularity over the second genu area. And in some cases, you'll be drilling down and you're surprised. You're like, oh my God, did I just drill into the facial nerve? Oftentimes it's not. Oftentimes it's blood vessels going in and you're looking at it, you examine it, okay, it's okay, you feel it's okay. You want to verify by going proximal. So long as you continue to check proximal, this gives you information about your integrity at the point of interest. In this area is where you start to get up to the 0.7 to 1, depending on the thickness of the bone. Now here, you're controlling largely the thickness of the bone. So as you thin the bone, you can get down more around the 0.7 range for this because remember, it's also getting a thicker epineurium. So you're going to expect that the milliamps required is going to go up. As you go down further into the descending, again, 0.7, maybe more towards 1. And as you get down to the stylomastoid foramen, you're going to need this kind of 0.1, 2, 1.5, okay, range. Now, when you get extratemporally, because you've lost the bone, but you still have the epineurium, it drops. So the expected stimulation for an extratemporal facial nerve is about 0.3 to 0.5 milliamps. So I use, in my technique for parotidectomies or any facial nerve dissections, I use microscope and I use stimulator routinely because I'm a microsurgeon. That's how my training is and that's how I learned to see it. So you can expect you don't want to overstimulate, especially with parotid, because with parotidectomy, if you're using the stimulator and you're overstimulator, in the old days, 30 years ago, we had, and they still have them, actually Medtronic has them at their booth. There's a small handheld stimulator, you put the one end in the muscle and the other you have a probe, and it basically has a choice of 1.5. That's it. If you use consistently 1 milliamp, you can get a neuropraxia by the end of the dissection. Of course, these patients will typically recover, but it's not so pleasant to wake up and see your patient with a facial paralysis. But now we have much more sophisticated monitoring systems, so you should reduce to the minimum amount of current necessary, okay? And I use higher levels to seek the nerve, and you can even use a monopolar probe, gently pass it into the parotid tissue as you're doing the dissection at a higher level to get stimulation. And then if you're able to keep it in that exact position, you can decrease the level of current, and it gives you information as to whether you're directly on the nerve in this location or you're near the nerve. Now, this is rather difficult to do technically because you either need a second person to change the settings, or you need to use this, the Medtronic system has a manual control. But as you hit these buttons in manual control, you're moving the exact position of the probe. So this will show you in a few minutes of what I'm working on to try to help with that situation. Now, show you this. This is an acoustic neuroma that we operated on in the VMA Military Medical Academy. And I'll show you a nice video about some of the nuances of using the system for this. So let me go here. And this video is about 12 minutes. Okay, I'll speed it up because I want to go to the important things. So we're sitting, and I'm using, this is a system by NCC, Electrophysiology Company. The research and development arm is in Shanghai, and their distribution arm is in Singapore. So this company, I don't have any financial arrangement with them, but I do have a research arrangement with them. And what's very nice about this company is they're very open to development, software development, and modifying the systems. It's very difficult with some of the bigger companies to get them to change the software for you, okay? And they do have a CE in one of their devices that was just recently obtained. So this device will be available in Europe, and there is a company, Medicus, from Poland that is planning to be a distributor. So their company will be distributed in Europe as well very shortly. So I want to go forward a little bit to show the differences between band stimulus intensities. Here's a little bit of the setup. And all of these videos, this video is all on my YouTube channel. So this video in full. So I'll show you something here. This is interesting. Look at this. So here was the place of the trigger here. And look at this. This was the mentalis. You see, 4,800 microvolts. So it's very important to look at the microvolt level and take those levels into consideration. So we're using 1.0, and this is pretty high. So if I'm able to get 4,800 microvolts in the mentalis, well, I can go down on the stimulation, okay? So you don't want to continuously and repeatedly stimulate at 1.0. I've worked with surgeons that, that with acoustic neuromas, they're using 1.0 everywhere and saying this gives them a sense of safety because they can confirm that the facial nerve's intact because they're using this high level of stimulation all the time. Well, that doesn't give you any localizing information, so it's not a good idea. You have to always try to achieve your minimum. And one thing I want to point out here, this is the highest level is in the lowest division. And this is something that I see frequently, okay? Almost always, not always, but almost always, your highest level is in the mentalis. So the traditional monitoring setup dictates placing for mastoid surgery, we place one here and we place one here in the corner of the mouth, right? We actually shouldn't do that. We should take this one and put it in the mentalis. It's the most sensitive branch. And many times you'll see that as you're going down lower and lower on your amplitude intensity, that the only one that remains to be above the threshold level that you set is the mentalis. So the mentalis is the most sensitive and the most important branch. It's also the most important branch for initial identification in the parotid. So it's also the one that's most vulnerable in the early dissection of the parotid. So for parotidectomy, I always have one in the mentalis, and I usually use 4 channels, okay? But if you have access to less, if you have access to a machine that only has 2 channels, which older machines did, just make sure you don't leave out the mentalis. Now, I want to show you a little bit here. We're going to go to triggered, passive free run, and now, yes, so let's see now, parameters. So you see, look at this, watch. Also, look, 351 and 100 here. The highest level is in the mentalis, okay? Now, there's another thing to look at is the latency. Now, in this particular device, the latency is automatically determined. So the latency is from the beginning of the stimulation to the point that you get a response in the EMG. And that's variable. It's going to be, if we look at the brainstem, and Jason yesterday mentioned that 7 for 7 and 5 for 5. So at the brainstem level, you're going to expect to see 7 milliseconds because of the long distance for the facial nerve, and 5 milliseconds for the trigeminal nerve motor division. So you can tell with larger brainstem lesions, it's sometimes not so easy to tell whether you're getting reactivity from the trigeminal, from the masseter, or the temporalis muscle, or actually from the facial nerve, especially with very large tumors where the brainstem could be distorted. But you can tell by seeing if your stimulation that used to be in the 7 range is now in the 5 range in terms of milliseconds for the maximum response. So that should give you an indication that you're probably seeing masseter. So 7 for 7, 5 for 5. However, as we go down, further progress along the distance of the facial nerve, you see we're getting relatively short latencies. So this is in the 4 to 5, about 4 to 5 range. That's expected. Okay, so in the peripheral parts of the facial nerve, you're going to have short latency just because it's taking less time for the signal to get to the muscles. All right? let's play a little bit and see what we have.
Let's go down to point 1. The different sensitivity of delivery than the
See? So I actually am go. So now I lost the stimulation except for one little spot.
setup.
And the reason why we still got it that one little spot at 0.1, that's very low. That's lower than we expect. But there's probably just a little dehiscence there. This is just right over the oval window. So you have to know that, you know. And I like to map it. I say, okay, if I'm a little further back, I may be at 0.5, but then there I'm 0.1. And remember these points, because you know that's your best access for determination. Now, at this point, we're going to also mess around a little bit.
And go to 2.
Okay, now look at this.
Pulse width, go down.
Look at this, see. So 4 hertz is 4 per second, tuck, 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 tuck. That's usually what we default to for our EMG, triggered EMG. But on a Medtronic system, NIM, it usually has a longer pulse width, but it's fixed. On the NCC system, you also have control over adjusting the pulse width. So if we want to get even more specific information, we can reduce the pulse width, and we'll see the differences. So now we don't get it. Now we... But now we're doing it 0.3. So we're able to use a higher level of stimulation in terms of milliamps, and we're also getting it only at the very exact point that we were getting it lower because of a little dehiscence, but at a higher milliamp level. And that's because we reduced the pulse width. So you can play with all of those variables, okay? So they're very important, like I said, to learn your system, learn your pulse width variation. Now, one more thing I want to show you is this. Watch this. Now, I've removed the tumor. And we're going to show you the stimulation of the facial nerve with a monopolar versus a bipolar setup. Now, this is a bipolar system. Nothing on the cochlear division. Okay?
You can go higher. Go
So-
to 0.07.
Okay, and this is very low, 0.07, but we're going to do it now on the bipolar. Nothing on the cochlear nerve. Now, with a monopolar, at this same location, I was able to get stimulation even if I wasn't directly on the facial nerve because of the spread of current. So when you get to the point of requiring very precise information, it's reasonable to switch over to a bipolar. Because on the bipolar probe, and look at this also. Look, where's the highest current? The highest microvoltage is on the lowest division on the mentalis. It's consistent no matter where we are, and I often see that to be the case. Okay, I want to show you one last video. We have a few more minutes, and then we'll get to questions. So this is something that I'm working on with NCC, and so again, this is NCC electrophysiology, and this is something we're calling the safe scan. So watch. What I'm going to do, I'm going to play it back for a second, is we're working on getting the stimulation to automate itself, okay? And so that every impulse that comes out is going, this is prototype software, experimental software. So this is from about a week ago. I had recently got access to the machinery, and according to our investigational protocol, we determined that we're going to just not interfere with the surgery. So we will only give it one run to the preset settings, log our results, and make adjustment for the next patient to alter the results as we want. So we don't take up a lot of additional time in the surgery. So this is a single run, first one that we've done, and to show you that there's a correlation between the decreasing level of milliamps and the microvolt threshold, and it helps us level out the minimal response and also generates a curve, which we're going to investigate and look into to see how meaningful this curve is in regarding to delayed outcomes and all these things, especially later on with acoustic neuroma surgery. This is a cochlear implant, so this is pretty straightforward. We don't expect much. But just to see, 8, it's descending, 0.6, 0.4, 0.2, 1, and at 0.8, and then it drops out.
And it started at 0.6.
Right? So it dropped out at 0.6. Now, I used, and then it's not there. So I used a 0.2, and this is what we ended up with. So we ended up with, 7,000, very high. And then you notice around this 3,000 to 4,000, it levels out despite the fact that we're going from 0.6 down to about 0.1. And we still have a reduction to 0.8, and we have, now it dropped out. So in the next iterations, we'll program it to get smaller intervals. And we also plan to have it seek the level, to stabilize it at the thing. But this is the first iteration. This experiment in the patient, this added 2 minutes to the procedure. Jason, I have a question for you. See, this is when the speaker asks the audience a question. Jason, can you explain to me why it does this? See, this was the EMG on the facial nerve directly through bone in the mastoid, and this is the microvolt response. And then it sort of has a flat plateau, and it drops out. And this is what we tend to see. Does this have something to do with, at a certain level, that there's a similar recruitment of fibers?
Yeah, the theory would be that as we get to those, particularly high stimulation levels, now we're recruiting, microsensory branches in there.
Mm-hmm.
So those are activating a reflexes. It won't initially show up at the same time.
Okay.
Obviously, reflex response is going to be longer latency, but it reduces the inhibition of the nerve.
Okay.
So after the first, half a second, now you'll get bigger responses for
Okay.
a little bit until we stop activating that.
Okay, so we're recruiting the activation so that it facilitates it even though we're going on lower current because it's been sort of pre-triggered by the current? Is that what you're saying?
So it's kind of like primed.
We're priming it, yeah.
Might even correlate with why heavy stimulation results in temporary facial weakness after wake up.
Yeah. So hopefully by the next session it will be about 2 years in London. I'll have more data. We're going to look at this data. We're going to look at potentially, with more skull-based surgery to see how these values change and how that correlates with long-term outcome. All right, so I'm going to wrap it up there. And we have a few minutes for questions. Anybody have any questions for any of our speakers? We have about 3 minutes left until the session is over. I think, Dušan, you answered already my question. I was going to ask you, what's the minimum test battery? And you made it very clear. These things can be easily done in the clinic in about 30 seconds without, and you actually make a big difference, I think is particularly important when you're seeing patients just with hearing loss. You may actually, look, we really have to go to MRI. Mike, I was going to make a comment. Also, another important, and on one of my videos in the mastoidectomy on the YouTube channel, there's a couple of soft tissue landmarks. So there are, in the incus bridge, you can bring that posterior tympanotomy all the way up to the soft edge of the incus. So if you look very carefully and try to look for it, there is the tendon of the incus. And it's a little white structure, so you have bone, a little white soft structure and bone, and you can drill all the way up to that and identify that tendon without drilling the incus. And then on the bottom end, there's little fingers of fibers going into the stylomastoid foramen. So there are a variety of soft tissue structures as well. Okay, thanks. Thank you all for hearing us out. Thanks very much.